I would like to thank the Ohio Department of Mental Health for partnering with us and for supporting this effort here today. Director Stevenson is with us this morning. She is sitting in the very back. We appreciate her support and her leadership in this process. Today really does mark the dawning of a new decade. It is a decade that offers some exciting opportunities and will challenge the way that we think about how we deliver services and document those services. Some of the things that are changing in this current environment include the federal parity legislation, which, as you know, now will require coverage for behavioral health services on par with the medical benefits that most people have. You have federal health care reform, which includes a lot of opportunities for the delivery of behavioral health services. Again, it's a coverage issue, and that behavioral health services are considered core benefits, so that's new and that's different for the folks that we serve. There is a growing recognition and data that demonstrates that in order for people to be truly healthy, they must have good mental health as well. And then, of course, there is momentum towards the delivery of integrated care, where we are finally reconnecting the body and the brain so that we are treating whole people as whole persons. And then the emphasis on the use of health information technology and electronic health records and electronic medical records. All of these things are important and provide opportunities as we move forward. The title for today's training also includes Aligning for the Future, and that is intentional because we must take advantage of these opportunities. We must really start to think and act differently. We must begin to align our practices with the standards of other healthcare practices. We must begin to start thinking of ourselves as specialty healthcare providers, and we need to start thinking in terms of data elements rather than paper forms. Today does mark a paradigm shift. The information that you hear today will challenge information that has been shared before related to documentation and the concept of medical necessity. Our goal today is to show you that federal and state laws do not create barriers, but really do allow providers to have the flexibility to document services in a way that is different and to still meet all of the required elements. It is reducing the administrative burden and allowing your staff to have more time to spend working with the clients that you serve. At the same time, still ensuring that we're documenting the quality and the clinical content of the information that we're providing. Before we go into the actual presentation, I do want to take care of a couple housekeeping things. Restrooms, if you haven't found them, they are out in the hallway, down the hall and to your left. We will not be taking a break during this presentation, so please use the restrooms at your convenience. If you have a cell phone, please put your cell phone on silence so that we are not interrupted by those. We are video recording this presentation today, so we will be doing that, and part of that is because at the end of this training, we will be putting together a DVD, and each agency will be provided with a DVD that includes a copy of this presentation as well as all of the training materials, and that will be mailed to each ODMH certified agency and board. CEU certificates will be available at the end of today's presentation at the registration desk. If you are a psychologist and you want CEUs, please make sure you have signed in at the registration table. In your training packets, on the left-hand side, you will find a copy of today's agenda. You will find the PowerPoint presentation as well as information about each of our speakers. On the right-hand side, you will find several things that we referenced today, including letters from the Ohio Department of Mental Health, the rules from Centers for Medicare and Medicaid Services, or CMS, that are the federal definitions for documentation, as well as the rules from ODJFS and ODMH that are being talked about today. For the structure of today's event, we will have a panel presentation from the state agencies. That will be followed by a question and answer session. During the question and answer sessions, we will be bringing around microphones so that if you have questions, we ask that you speak into the microphone. Also included in your packet, you have note cards. We will also, another way to get your questions asked is to fill out the note card, and we will collect them, and as time permits, we will ask the questions that are on the cards. I will tell you, in the training that we did in Akron last week, we did not get through all of the written questions. We will also be compiling a Q&A document that will be included or sent out as well. So we have about 30 to 45 minutes that we have allowed for questions, so we'll do as many as we can during that time. After we finish with that question and answer session, we will have a panel presentation from 3 providers who participated in a pilot using the new progress note rule that will share with you some of the lessons that they've learned and the experiences that they've had as they've changed some of their documentation practices. With that, before I introduce the panels, I would like to Director Stevenson wanted to make sure that everyone at all this is the 5th site that we've done, had an opportunity to hear a message from her, and she really wanted to be with us, and she is physically with us today, and I'm sure she's going to love watching the video of herself. But I do want to share her welcome message with you.
Greetings. I'm Sandy Stevenson, Director of the Ohio Department of Mental Health. I want to welcome you to Documentation and Medical Necessity, Aligning for the Future. I truly regret I can't be with you because this issue has been near and dear to me for many years. In Ohio and across the country, behavioral health documentation has differed greatly from the general medical field. All of you are aware of how much time you spend on a daily basis with your consumers. You're equally and perhaps more aware of the time you spend with paper. When I joined the department and talked to staff, we agreed to come together to look at regulatory reduction, particularly in the area of documentation. We're very pleased today to be joining with all of you to discuss the culmination of that work and what we consider to be rational documentation, regulatory reduction. There should be several outputs from this work that you will notice immediately should you choose to implement this new opportunity. One, as you provide services to consumers, you should gain efficiencies with regard to the actual documentation that is required, and you should simply have more time to spend with the people you are serving. In addition, we all know today how much paper goes into our client medical records, and we know if you are a physician, a nurse, a CPST staff member, a social worker, or a counselor, and you need critical information from that file, how very difficult it can be to find that information. With the documentation product that we have created, the rules that support it, it should be easier for any practitioner to go more quickly into any client record, whether it be electronic or paper, and find specific information that is critical regarding that patient or client consumer's care. It is also important to note that as we move along with the new environment of healthcare reform, and we look at the issue in the future of health information exchange, that the process that we are putting in place today will allow, if not encourage, providers to participate much more successfully in the new world of exchanging information. You will see that much of the documentation we're suggesting is driven by pull-down lists, checkboxes, if you will. Information in the future can be more easily packaged in order to travel electronically to inform other providers of the care that you are providing your consumer. I hope you enjoy the day today. I hope you are excited about the opportunity this affords you, your provider organization, but most importantly, the consumers you serve. Thank you.
In addition to her welcome, Director Stevenson wanted me to extend her sincere appreciation to the agencies that participated in the pilot project that was done when we were testing what we were talking about or thinking about around the new progress note rule. So with that, I would like to welcome and thank our panelists from the state agencies for their participation. First, you will hear from Dan Arnold. Dan is with ODJFS from the Office of Ohio Health Plans, which is otherwise known as the Medicaid Office. He will be followed by Janelle Pecano, who is with ODMH. She is Chief of Standards Development and Administrative Rules. Janelle will be followed by Terry Jones, who is also with ODMH, the Office of Medicaid, as the Compliance Manager. Dan?
Good morning. My role in the presentation session today is to give you a little general overview about the Medicaid program and also to tell you a little bit about the technical work that went into revising the 06 documentation rule and ODJFS's role in that. First, a little bit about the Medicaid program. As you're aware, it is a health care program that's jointly funded by both state and the federal government, with the federal government picking up the majority share of the cost. In Ohio, the federal share is about 63%, but currently with some enhanced funding that's available, the federal government's picking up about 74% of the cost. Of course, the states and Ohio using various means to make up the rest of that. The Medicaid program provides an opportunity for individuals who may not have the availability of health care services otherwise to get those services. And there are many eligibility groups and categories of consumers that can take part of that. For the most part, they're low income, and it's some of the groups are children, pregnant women, families, and then some elderly individuals as well. And there's many categories and caveats and restrictions on that, but it is a fairly wide group of individuals that can participate in the program. For those states that participate in the Medicaid program, the federal government requires that certain medical services be provided, and those are stated and listed, and individual states don't have any options about whether to provide those or not. They are required to do so. However, each state can have an optional list of services that it wishes to provide. And Ohio has a pretty thorough list, and as part of that optional list, behavioral health services that you provide and are interested in are part of the optional list. As far as the administration of the Medicaid program, the states are able to administer the program. The federal government gives them a pretty wide latitude about how they may do that. The federal level administration that's responsible for doing that is CMS. That's the Centers for Medicare and Medicaid Services, and they work with each of the states in various ways. The CMS provides some of the rules and regulations that states have to follow. They also provide technical assistance for states in setting up their programs, administering their programs, so they can provide those services and assistance to states whenever they request that. Also, any changes that for the most part, that states would want to make in their Medicaid program has to receive approval from CMS. Each state is required to have a state-level agency that's going to administer the Medicaid program, and that's called the single state agency. It's actually a formal term that's used. In Ohio, that's ODJFS, the Department of Job and Family Services. And the way we do that is to have a very large document that outlines all the categories of services, the eligibility groups that can participate, and the services that are going to be rendered in Ohio. And that document is called the state plan. And Teresa was talking about a little bit about paper earlier, and the state plan has lots of paper in it. It's still on a paper format. It's several binders and very large. And anytime we make changes in that, as I mentioned earlier, we have to get CMS approval to do so. As far as compliance in the Medicaid program, there are several sources of rules and regulations. As I mentioned, CMS has some that they develop at the federal level. And then also within Ohio and other states, there are rules and regulations. In Ohio, we have the Ohio Revised Code that sets statutes that are going to govern the Medicaid program. And then built on that are the rules, the Ohio Revised Code rules, that actually operationalize both the federal and the ORC rules and regulations. And hopefully the OAC rules are a little more user-friendly for you as providers and stakeholders to have a better understanding about what you need to do on your day-to-day operation to carrying out your various services. As you're aware, Medicaid providers in Ohio are required to abide by both federal and state rules and regulations, and that includes the OAC rules. So we certainly encourage you to be familiar with the OAC rules, and if you ever have any questions about those, what you need to do, certainly feel free to contact me or someone within ODMH, and we can certainly help clarify that for you. Now a little bit about the work that went into revising the 06 documentation rule. Basically, there were three sources of information that providers and other stakeholders are interested in when it comes to documentation requirements in the Medicaid program, especially for behavioral health services. And these are the Medicaid State Handbook, 4221, paragraph D, and then an ODJFS administered rule, which is 5101, 32702, paragraph G, and then, of course, the documentation rules that you're familiar with, 5122, 2706, that was recently revised. Now, in developing the revisions on the 06 documentation rule, what we wanted to make sure was that we captured all the both federal and state documentation rules and regulations and made sure when the 06 rule was revised that there wasn't any kind of conflict between these three sources of documentation requirements. So ODJFS worked really closely with ODMH to come up with a new rule, and the way that we did that on the ODJFS side was to come up with some legal language, actually our legal office developed, that we could put into an ODJFS rule. And that was the ODJFS's role in developing and revising the 06 rule. Our legal office developed the language, and we wanted to actually put it in the 32702 rule. And that would kind of make sense because that's the rule that currently has the documentation requirements as they apply to Medicaid providers. However, we weren't able to do that because the 02 rule is currently under a temporary restraining order. And the courts do not allow us to make any kind of changes in the 02 rule. So we had to look for another venue to be able to do that. And so in consultation with our legal office, we found another rule, the 5101, 32705, that many of you would be familiar with it as well. And it made sense to use this rule because it had to do with mental health services, and it also had to do with reimbursement. So it seemed to be a good vehicle for us to be able to insert the new language that we need to put in there to provide compatibility with the revisions in the 06 rule. And the middle paragraph that you see there is the language that our legal office came up with that was put into the 05 rule. And while it might seem a little technical there, basically what it's saying is that you as providers and stakeholders, when you satisfy the requirements that are in the 06 rule, then you will be in effect fulfilling the requirements that are in the 02 rule, paragraph G. So you can rest assured that the 06 rule is capturing everything that's in the paragraph G of the 02 rule as well as the federal requirements as well. So the 06 rule can be sort of your one-stop source for looking for your documentation requirements. And that was really a quick overview over Medicaid and what we did on the 06 rule. There's my contact information. As I said, if you ever have any questions on JFS rules, please feel free to contact me. And I think we'll have a little time a little later on where we'll be taking some questions with some other panel members as well. So thank you very much.
Good morning, everybody. I want to thank everybody for coming. It's a beautiful morning. I'm going to do my presentation from two handouts. Obviously the PowerPoint, everybody probably has that pulled out, but on the right-hand side of your packet, there is also a document, I think it's toward the back, and it says 5122-2706, intent and explanation. So basically it's the rule, each paragraph of the rule with some additional information. And so you can use that to sort of follow along or take notes. While you're looking for that, I want to talk a little bit about the process to this. A little bit over a year and a half ago, several of us at the department, we got an email from Director Stevenson tasking us with looking at the progress note rule and finding ways to reduce the regulatory requirements and to move toward using checklists for documentation. We did some internal work at the department, consulted with CMS, the accrediting bodies, other relevant areas of the rule, And then we took this outside and brought in providers, boards, trade representatives. And I really do want to thank the pilot agencies. When you participate in a pilot project, a lot of times you get to do something different when you're one of the pilot agencies. Well, these agencies, when they were doing their documentation, because they still had to bill under the old rule, they had to write 2 progress notes for every service section. So they had to write the original one to support the billing, they had to write a second one, they had to do analysis, and you'll hear a lot more information from the panel representatives, but we really do appreciate the time and the effort that those organizations made in helping us get to the rule that we developed today. Okay. So let me tell you a little bit about that document, the intent and explanation. How many people are really excited about this new rule? A lot of people, and see some hands up, and okay, so it's a gift that we give to you, but we're going to demand, I'm going to demand, because I'm the one up here on videotape demanding as a state official. We're going to demand, forget about the old rule. And during my presentation, I'm going to talk a little bit. There's some slides up there. It'll say previous requirements. Please don't make that the only things that you remember from the day. It really is the previous requirements. It's been hard for some people to accept. I mean, we were asked at one of the trainings, one of the questions was, is this true? Can we utilize checklists? And yes, it is true. We also know, and Terry will talk about his presentation, oral tradition and sort of how things develop and over time, and this is what you're taught and this is what you're learning, and a lot of times we don't even know why we're doing something, it's just what we were taught. And along with that, a lot of times myths develop. Was asked at one of the trainings in documenting a progress note, is it okay to use personal pronouns? And that was probably one of the trickiest questions for me to try to figure out, what's this about? And when you think back, and I used to document this way, this writer and the client would blah, blah, blah. We were taught, you can't use I. It's against the rules. The department doesn't allow it. Well, I assure you there's no rule. We don't address that in our regulatory requirements. So really the reason for this intent and explanation document is to debunk the future myths that are going to develop about this rule. It's going to come, there's an audit, whether it's a board, it's a surveyor, whether it's your clinical director at the agency. So that's something that people can always look back and reference to see what is okay, what is allowed, what might not be okay. As has been talked about, we do anticipate less writing with this rule. There might be times when long narrative is important. That's okay. It should always be based upon clinical need, not a regulatory requirement. It's a flexibility. And another big area of reduction that I'll go into more detail is that the option to do a daily note rather than a note for each service contact. So I'm going to start with paragraph A. And agency shall document progress or lack of progress. The last line, documentation of progress may be done through use of checklist and or brief narrative. Flexible, individual clinician, agency gets to determine that. And you can utilize both. One of the important things also to know is it doesn't have to be the same. Once a clinician sees a client and uses a checklist, it doesn't mean the next time they can't utilize the narrative. You can go back and forth. I think agency protocol is going to determine it. Again, it's the individual judgment. We know when we did the pilot, we asked agencies to redact the agency name and client names, and they sent us some of the pilot examples. And I can tell you that for the most part, it was the licensed individuals who had the hardest time being brief. So I know that's kind of shocking, but we'd see it, and they were writing there. They were writing in the margins. They wrote on the back. I think, were writing on their arms. But as you also know, you can write a page and not say anything. You can write 2 sentences and just tell the most wonderful story. It might be times that long narrative is important. Again, we don't want to limit, we don't want to prohibit, but we want to allow the flexibility based upon the agency need. Previous requirements, narrative description, clinical observations, description of the response, both in ours and then JFS had their requirements too. Some of it which mirrored ours, they use the term behavior and response. Paragraph B is each individual staff providing services shall document progress or lack of progress each day that a service is provided. I do want to point out, it might seem obvious, the requirement to document progress is not new. When we sent the rule out for the draft rule for public comment, there were a few people that felt this was a great new regulatory burden. Somehow the department was adding a significant new requirement. I'm not sure how those people read the rule and what they thought was different, but the expectation of just to document progress, that concept is the same in this rule as it was in the previous rule. And remember, that previous rule is the one I asked you to forget about, so hopefully it's you going, what previously rule? Documentation has to be completed in the old rule for each service contact. In the new rule, each individual person shall document progress or lack each day that a service is provided. So yes, if you have 2 CPST contacts, 2 counseling, if you have 3 or you have 4 CPST contacts, that's the service where that's most likely to occur. You can do that in one daily note rather than a note after each contact. Okay. The exception to that is the provision of group services when it's a minimum of 1 staff person completes the progress note documentation. Agencies have some different protocols for group notes. Sometimes one person writes them on behalf of all the people. If there's more than one person providing group services, sometimes one person writes, everybody co-signs. I would suggest that people also reference their accrediting body requirements. When multiple contacts, like I said, are provided, the staff may complete 1 progress note rather than per service contact. So a little bit about rule writing, may versus shall. A lot of times, the majority of times in rules, you do see the terms shall. Shall or must, that's a mandatory requirement. It's something that has to be done. May or should, it's a discretionary action, one that the agency or the provider may or may not take. They can use their own discretion in doing that. So when we're talking about a daily progress note, again, it's something that you can do. In the same way, checklist or narrative, the flexibility is up to the person. You can also go back and forth. Maybe, you see the client and see them 2 times and you write a daily note, and 3 days later there's 3 phone calls and or in-service contacts for CPST. You write a daily note, and the following week there's something in a session that was so significant you want to write just 1 individual note. You're going to sort of document the other contacts in that day in their own note. That's certainly permissible. Again, it's up to you, and there's no, once you not make a commitment, always going to do a daily note, can never deviate from that, or the same way that you're always going to do it per session. Okay. It is each individual staff person, so if 2 people provide CPST to the same client in the same day, then each person must write his or her own note. So you cannot write 1 note to cover 2 individual sessions provided by 2 different providers. Okay. Again, when the same staff person provides more than 1 service, so if you have a person who provides a counseling service and they provide a CPST service all on the same day, then they must complete 2 separate notes. So again, 1 note per service, per staff, per day. Get to paragraph C, talk about the documentation requirements. It's the date of the service contact, okay. The time and day and duration of each service contact, and the location of each service contact. And for C2 and C3, those elements, when you're writing a daily note that covers more than 1 session, those elements must be documented for each contact. If you want a example to look at, if you look at Greater Cincinnati Behavioral Health, their CPST note that's on the right-hand side of your packet, you'll see toward the top they have I think, 3 or 4 lines, and you can see, I think it's start time, end time, and then there's some modifiers and location codes, and you can see where that is done for each contact. You cannot, if you provide see a client from 11 to 11:30 in the morning, and then from 12:15 to 1 o'clock, you cannot combine all those times and make it in just 1 hour and 15 minutes. You must document those 2 separate times. And for duration, it may seem obvious, but we do get these questions over time, and sometimes when we talk about debunking those myths that you can do it start time, end time, or you can put start time, 12 o'clock p.m., and that it was a 45-minute session. Both ways get to the information that's required. C4, documentation shall include a description of the services rendered. And I would reference you back to paragraph A. It can be done through checklist and or brief documentation. This is where I'm going to start talking about diagnostic assessment, ISP, and progress note. And you'll hear me talk about that a few times through the rest of my presentation. You'll hear Terry talk about it through his presentation. That really is the key to understanding this note and understanding the documentation and what needs to be put on a progress note. So I don't want to sound redundant about it, but documentation should flow. Somebody can look at and be able to pick up the record and read these and understand what is going on. Conversely, your progress note in and of itself doesn't have to support everything. The progress note doesn't need to repeat the information that's in the diagnostic assessment. It doesn't need to repeat the goals and objectives that are on the treatment plan. It just needs to be reflective of those documents. C5, whether or not the intervention is specifically authorized by the service plan that was developed based on a mental health assessment. This is probably the element that has brought up the most questions. It would be, if I asked you to go back and read the whole intent and explanation document twice, it's probably a good idea to read this section 3 times. But it's really not as complicated as it seems. In the outline there that I give you, I try to give some different examples of ways that you would accomplish it. This element, documentation of this element, is really going to reflect back to C4. So, for example, if you're utilizing a narrative, and that's how you choose to document your session, and it's a well-written narrative, that might meet that intent. And for an example, you have a client who maybe is diagnosed with an anxiety disorder, and that's one of the goals on the treatment plans and objectives is to reduce the client's anxiety. And in your narrative where you describe the service interventions, you might have been describing utilized some relaxation therapy and guided imagery to assist the client. Well, clearly the link is there. It's shown, it's a short statement. You would have met the intent of that standard. If you're utilizing some checklist, you're probably going to need to go a little bit farther. And this is one of the areas that the department, when we looked at the regulatory reduction and less information for when people do need to either come back, look at either do some audits, or when staff are documenting. We want the staff to think, is this based upon the treatment plan? Is it based upon the diagnostic assessment? Sort of to ask each staff person, ask him or herself that question when they're doing the documentation. If it's not, it might be every once in a while there are those sessions where something happens and it's just, maybe the client was driving the session in a way that's not reflective, but that was a one-time isolated incident. Or it might indicate it's time to look at the treatment plan, maybe update the treatment plan, and add a new goal or objective. Sometimes you might meet this in your documentation by doing what I call sort of a yes-no prompt question. And that might just be repeating that statement of C5. And I try to go back, but I don't think I can do that properly. I'm going to go forward here. So to the yes-no prompt question, you might say, is the intervention specifically authorized by the ISP that's based upon the diagnostic assessment? In essence, you're just repeating that element of C5, and it would be yes or no. Some people, you can. Again, it's not a requirement. Some agencies had indicated they like the term medically necessary, so they might have on that a yes-no prompt statement that says, is the intervention medically necessary based upon an ISP that was done, developed based upon a mental health assessment. Again, you would answer a yes, no, and it's that simple to do that. Some might have client-specific checklists. I think this is more likely to be perhaps the wave of the future in electronic records. But when you look at those checklists, going back to the options on C4, that somebody could put what are the interventions that were provided, if they're individualized to a client, they're not generic to the agency, but maybe based upon diagnostic assessment, treatment plan, you've developed some client individualized checklists, that may also meet this element. Back of, so C4 and C5. And understanding how this gets to some of the regulatory reduction, if you look back at slide, I think it's 16, that talks about the previous requirements, JFS rule, behavior and response. So you have a diagnostic assessment, it's done, the client came in, very sort of difficult to engage client, they've stated a commitment to participating in treatment, but they're not very verbal, unwilling to talk about their childhood sexual abuse. It's on your diagnostic assessment. So you develop some treatment plan goals about that, for the client being able to engage in treatment and also be able to discuss their childhood sexual abuse. The client comes in, difficult to engage, but they come back the first session, the third session, the 7th, the 11th. In the old rule, you'd probably be writing, child was difficult to engage, answered 1 or 2 word answers to open-ended questions, got more information from yes, no. So you would write that at each progress note. Same information, nothing's really changed, but in the old rule, you'd have to be writing that down each time. In the new rule, we have that information. You don't have to do that. You don't have to document any of that. You're not going to be documenting. You're going to put your intervention, but you're not repeating yourself, client difficult to engage, answered 1 or 2 questions each time, until maybe something changes. And that's the point where you're going to be putting some more information in your documentation. We go to, I know I skipped a part. We'll figure out how to go back. There's that exception to that where farm management and crisis intervention. In the mental health assessment rule 5122-2904, it states that a mental health assessment has to be completed prior to the initiation of any mental health service. And it gives the 2 exceptions then, farm management as the least restrictive alternative prior to completing an assessment, or crisis intervention when that's not listed on the treatment plan. So in those cases, when you're documenting or meeting this C5 element, you would be putting the presenting problem, and that's just part of good clinical documentation. It's not something that really needs to be a regulatory requirement, and you would be putting the information. When you meet the elements of documentation, either the crisis intervention rule, you're documenting according to those standards, or the farm management, you should, as long as you're documenting appropriately, meet this requirement of C5. Presenting problem, develop a plan, and here's the client agreed to it, and it should just all within that note meet that C5. So now we'll go up to C6. The assessment of the client's progress or lack of progress, and a brief description of progress made, if any. And again, this can be sort of yes, no. And then when the client has made progress, we then want you to give that description of it. You can do that by further utilizing checklists if that's what your electronic record system or your record system supports, or you would just give a brief description of it. Going back to the client who's difficult to engage, but comes every session and not willing to talk about their childhood abuse. And so up till now, you know, we're at the 15th session, you've just been documenting your interventions that you provided, but this comes up and the client comes in and kind of starts talking and pours everything out. This is the time to write that down. And some progress has been made, so you've checked yes, and you've given some additional information. It's sort of like, it's not a diagnostic assessment update per se, but it's updating the assessment and the functioning of the client. C7 is significant changes or events in the life of the client if applicable. If applicable means that that information has to be documented if it's true, if it's present. You don't have to document anything if it's not there. So C6 always has to be documented, C7 only if something's occurred. Significant changes or events in the life of a client, those are things that are important and may be the focus of treatment during that session or in the future. That's sort of your guide. You know, what are significant events? It is individualized. There's no magic list that the department's going to post of these are all the significant changes, and if that occurs, it has to be written down. If you have a client who comes in and the client says, I got in a fight with my brother last night. This client is always fighting with their brother. That's sort of their relationship. That's how they work. It's really kind of no big thing. You wouldn't write it down. Another client comes in and says, I got in a fight with my brother last night. This client, their brother is their only support system. It's very unusual. You've never heard of them having a fight. You're going to explore this. What happened? How's the relationship? Were they able to mend it? Where's it at right now? And this might be a significant event that you would write down. People need to utilize clinical judgment, and yes, I put it in writing on that intent and explanation, common sense. So sometimes it seems that common sense and regulatory requirements don't always go hand in hand, but we really want people to utilize that. Think continuity of care. The next person coming in, picking up the clinical record and reading it, are they going to understand what is going on? And I can assure you, when we talked with the accrediting bodies about our movement toward this new rule, that was one of the concerns expressed. They just wanted to make sure continuity of care needs are met and the information is documented in the clinical record. C8, recommendation for modification to the ISP, if applicable. Again, if it's not there, you don't need to write anything. If there is a recommendation, indicate it and why. That does not mean that there has to then be a modification to the ISP. It means somebody needs to look at that, again, in accordance with the agency protocol. This might be a situation where you have an independently licensed clinician providing the service. That's the only service that they're getting from the agency. They can discuss it with the client, maybe make that modification to the ISP, do it all in that session. In other cases, it might trigger an agency just a clinical staffing or review. We just want somebody to look at it. But again, it doesn't mean there does have to be an update. C9 is the signature and credentials or initials of the provider of the service and the date of the signature. So again, to remind everybody, in 5122-2930 of the Administrative Code, it's the new service matrix that we put forth last July 1st. We also tried to re-emphasize in the wording of that rule, when you sign your name, you must always include your credentials, and they do need to be the credentials either spelled out, qualified mental health specialist, or the abbreviations that we identify in the matrix, QMHS for a qualified mental health specialist. If you want to utilize initials, you can do that. What you would do then is have in the clinical record, I would write Janelle M. Pecano, LISWS, and then I would have my initials that. And that would be a signature sheet that needs to be copied and put in each client's record so that we have that information. And then I could just sign my name utilizing my initials if I want to do that. We did check with the accrediting bodies on that. That is acceptable to them. When you read the CARF standards, for example, when they talk about signing progress notes, they do have a notation that signature or initials are not acceptable. But they did say in our conversation with a signature sheet located in the chart, that is fine. They just don't want to see initials without any reference back to those initials. Certainly, if you're utilizing an electronic record system, you have to be in compliance with our Security of Clinical Record Systems rule, and that also references the revised code. 2706D, documentation may include a notation there is no change in the client's risk of harm to self or others, or if there is a change, the results of a review. The client's ideation, intent, plan, access, and previous attempts. Again, remember slide 20, may versus shall. You don't have to do this. This is something that the department felt was very important, reflective of good clinical practice. There were some concerns expressed by many of the agencies in terms of how this is documented and where it's documented and the protocols. So in the spirit of compromise, we went with may. It's not something that ever has to be there. I think agencies generally do a good job documenting this information anyway. You do have to be mindful of what's frequently referred to as the duty to warn or duty to protect. It might be, this might be information you put in a progress note. It might be that you have a separate form. Then you might have a protocol, a staff person that, depending upon their licensure or credentials, if they have a concern, they just put a little bit of this documentation and then they refer the client to be seen by somebody else within the agency or perhaps a crisis screening agency outside of the agency providing the service. The accrediting bodies, one of the big questions. We talked with them at the beginning, throughout. They all have received a copy of the final rule, and I've discussed, set up a session to discuss it. Basically, no concerns noted. Again, continuity of care. I think when you go back to checklist and or brief narrative, there's no requirement for this. I think what you're going to see is over time, over the course of treatment for an individual client, it's probably be a combination of both to get at the information, the significant information that needs to be documented. Again, it's documenting based upon clinical need, not regulatory requirements. I also want to give you the So Quick update, and many of you may have heard this by now. The department is not going to be updating the So Quick forms based upon the new progress note rule or in the future. The current forms, they remain on our website. Agencies can make modifications to them if they'd like to. When you go to the So Quick website and you download a form, if you download the form, it is locked. But the website also includes the instructions for how to unlock it. So if you want to add the prompt, like significant changes or events, if you want to put that in, the recommendation for modification to the ISP, you can do that. And then you can relock it, because you know what happens when you send unprotected documents to your staff. They make changes. Even though you have a policy, this is the form, nobody changes it, we want everybody documenting the same way. But if you'd like to do that, you may do so. At some point, they will come off the website. That's not anytime soon. We're not anticipating it. We are getting together the official communication from the department that will go out and that will explain that further. However, when So Quick was envisioned, we weren't anywhere near where we are today with electronic records. As they talked about, sort of transporting information back and forth among different service providers, and So Quick, you know, with what we can do with it, isn't really supportive of that initiative. The last thing is we will also have some examples ourselves from the department, so when you check back, because all of the documents are going to be posted to our website, and we'll also have some examples of our own progress notes that will be there. So other than that, I want to, introduce Terry Jones.
Good morning, everyone. Thank you, Janelle. A couple of things that I wanted to begin with. First and foremost, thank you all for coming. I think this is important information, and certainly when you leave today, you will leave with the ability to go back and document less and not worry about that. The second piece, and this is something that came up in the 5 other trainings, the one question that we had repeatedly was, did CMS approve of this? And as Dan indicated in his opening, CMS is the federal agency that regulates all states, and we talked with CMS throughout this process, and they were encouraging us to move forward. So when you operationalize this back in your agencies, you don't have to worry about CMS coming into the state and taking back dollars as it relates to our checklist format. Because the rumor was that other states that had utilized a checklist had huge paybacks. And the reason for those huge paybacks was not because of the checklist, it was because they didn't meet their own state plan requirements. So, you were safe. And I think this is on video, so. The other point that I want to make is I'm not going to address any particular county on this videotape presentation. All right, this is where the fun begins, okay? Medicaid and clinical documentation. In Ohio, Medicaid funds behavioral health care services through the psychiatric rehab option. And again, many staff aren't aware that our services are funded through an optional Medicaid service known as the psychiatric rehab option. And again, Medicaid is broad. It's very complex. It has 30 or so mandatory requirements that must be met. In Ohio, we fund our healthcare services, our behavioral health care services, through a psychiatric rehab option. And I think that's important for staff to understand, as it is important for staff to understand the concept of medical necessity that we'll talk about. The MRO, or the rehab option, pays for services rather than programs. And the last bullet are the 6 covered services that are currently reimbursed through Medicaid in Ohio. Rehab services are defined in federal law at 42 CFR 440.130, because again, we have to speak this way because we work for the state, and I figured you guys would appreciate this. Since my predecessors talked in code, I need to repeat the code. So it's 42 CFR 440.130, and what I want you to pay particular attention to is the restoration of the individual to the best possible functional level. That's what we're attempting to do through the rehab option, is to restore the individual to the best possible functional level prior to the onset of the mental illness. That is the whole concept behind rehab services. Providers bill for rehab services on a client-by-client basis. The amount that a provider can bill is based on the client's assessed needs as outlined in the mental health assessment, treatment plan, and the actual services that are delivered. And the rehab option provides very clear guidance for delivering, billing, and documenting services. Services must be related to a mental health diagnosis that is identified in a mental health assessment with goals and objectives specified on an individualized service plan. And again, as we referred earlier, services must be medically necessary. You're probably questioning yourself, what is medical necessity? Segue. This is the federal definition for medical necessity. Pay particular attention to the rehabilitative notion. It's provided for the symptoms, diagnosis, and treatment of a particular disease or condition. And again, when we diagnose someone with a mental health issue, that then meets medical necessity for services to begin. It doesn't necessarily mean that all services that are then delivered are medically necessary. And one of the questions that we always have to ask is, why does it take a mental health professional to deliver this service? This is ODJFS's Medicaid rule for medical necessity. As you can see, it's very long. And it also talks about, at the end of the paragraph, medically necessary services are defined as services that are necessary for the diagnosis or treatment of disease, illness, or injury, and without which the patient can be expected to suffer prolonged, increased, or new morbidity, impairment of function, dysfunction of a body organ or part, or significant pain and discomfort. So if we withdraw our services, will this happen? It's a question that we have to ask ourselves, especially for those clients that we are seeing on our recovery teams or those that we refer to as in a maintenance stage of treatment. So again, ask yourself the question, if you withdraw these services, what is going to happen to that individual? A medically necessary service must meet generally accepted standards of medical practice. Are you going to deliver the same service or a similar service at another agency that that client is receiving at agency B? Must be appropriate to the illness or injury for which it is performed, as to the type of service and the expected outcome. It must be appropriate to the intensity of service and the level of setting. For example, if you're providing a community-based level of care, is your level of care more restrictive than if that person was hospitalized? Are you seeing that individual more than they would be seen on an inpatient basis? Again, it has to be appropriate to the level of care and the intensity and level of setting. You provide unique, essential, and appropriate information when used for diagnostic purposes. This is one of my favorites, federal government. It must be the lowest cost alternative that effectively addresses and treats the medical problem. And 6, it must meet general principles regarding reimbursement for Medicaid-covered services found in Rule 5101:3-1-02 of the Administrative Code. You're asking yourself, medical necessity. Where does it begin? Well, it begins with your agency at your point of intake, and it begins with a qualified professional that is an eligible provider of that service and that can assess that individual in terms of what their needs are. The assessment is both clinical and functional. You derive a clinical formulation, which is the support for the diagnosis, and as we all know, there must be a diagnosis in order for us to bill. It also determines the level of care, and we all know that it orders treatment. So from the assessment, we develop a treatment plan that becomes your order for treatment. Keep in mind scope of license issues, and we've addressed this in the other trainings. You'll never believe how many phone calls I get from agencies that start the conversation with, "Terry, you'll never believe what happened." I said, well, try me, because maybe I haven't heard this one. We had an LPCC that was delivering diagnostic assessment services, and they allowed their license to lapse. So for the last year, we have billed mental health assessment. And we billed that with an ineligible provider. What do we do? And then the dreaded words, pay back. So, make sure that your staff are fully licensed and credentialed. You must have an appropriately qualified clinician delivering clinically appropriate services and interventions, delivered at the appropriate intensity and duration. What this refers to is, as an individual is progressing through treatment, and that person is well into their recovery, are you delivering the same services at the same intensity and duration as you did previously? Or as that person recovers, are you starting to titrate the services? For example, someone who's been in service for 5 years or more, and they're doing well, are they receiving the same services that someone that is new to your agency? And does the treatment plan reflect that? Again, all of this is directed by an individualized treatment plan designed to improve functioning and symptoms or prevent their worsening, which we talked about earlier as part of the medical necessity piece. And it's based on assessed needs and an approved diagnosis. Documentation is required by all payers, not just Medicaid. And again, we reference Ohio Administrative Code here. All Medicaid providers are required to keep such records as are necessary to establish medical necessity and to fully disclose the basis for the type, extent, and level of the services provided. Again, your documentation is just simply reflecting in your progress note the interventions that are being provided. As Janelle indicated earlier, they do not have to stand alone. Okay? That's where we talk about the golden thread. I also like the fact that Janelle wove in debunk, because she said that she was going to put that as part of her presentation. And she used it twice today, debunking. Documentation focuses on the interventions delivered to meet the goals and objectives and the consumer's progress towards meeting those goals and objectives. This is where the paradigm begins to shift. And again, for those of you who have been around long enough, you'll remember Robert Wood Johnson, and you remember all the dollars that flowed in. And basically, the message was, do whatever it takes. It was from cradle to grave. And we provided everything. We moved people out of the state hospitals. We moved them into the community. We took them shopping. We took them to McDonald's. And we billed for all of it. Okay? Those times have changed. And so now, our service focus is on teaching, not providing. It's on cueing, reminding, training, and overcoming barriers. Medical necessity is based on functional criteria. And this is my own issue, and that's why it's in red. Community psychiatric supportive treatment is not case management. Okay? CPST is one of the 6 covered services. It is a direct clinical service. Case management has a very different definition federally, and it is not a direct clinical service. It is a referral, it is a linkage, it is a coordination of care. So, when you write into your medical record that you're delivering case management, you really aren't. You're delivering CPST. Because again, that's what Medicaid reimburses us for. In all situations, the ultimate goal is to reduce the scope, duration, intensity of medical care to the least intrusive level possible, which sustains health. In other words, is to put ourselves out of business to then move on to the next client who needs our service. And again, part of the recovery model is to move individuals from a dependent status to an independent status. And the Medicaid goal is to deliver and pay for clinically appropriate Medicaid-covered services that would contribute to the treatment goals. Within the rules, the Medicaid rehab option encourages a focus on recovery and consumer-centered services. The consumer's goals and needs will drive the priorities within the treatment plan. Consumers will be reviewing their services and their progress towards goals with providers on a regular basis. The consumer must participate and work towards measurable goals with the right amount of provider support, which means that the consumer needs to be a part of their treatment plan. And I've worked in community mental health, and I've had my staff come to me and say, Terry, the consumer said just write down whatever it is that you want, and I will sign it. And so they did. But again, keep in mind that this is the consumer's treatment plan. And as we engage the consumer, hopefully, they will become more committed to the development of their treatment plan. And again, signature does not necessitate that the client has been involved. It just means that the client has signed. Rules that are incorporated into medical necessity for payment purposes. Consumer must be able to be an active participant in their treatment. Thus, they must contribute to their treatment process. The consumer must have the sufficient cognitive ability to benefit from the treatment. And one of the questions that we got before was, if we're serving someone who has a dual disorder, both mental health issues and MRDD issues, are you going to say that they don't have the sufficient cognitive ability to benefit? And the answer is no. We're depending on your clinical judgment. And we're also depending on your clinical review to determine whether or not this individual is benefiting from your treatment. And if they're not benefiting, are you looking at the treatment? And are you changing the treatment to amend whatever needs to happen to address that treatment issue? But again, it's your clinical opinion as to whether or not that individual is benefiting from the treatment. The documentation must be clear about the consumer's participation in treatment. Besides being present during the intervention, what else occurred? Evidence that the plan has been developed with the active participation of the client, and progress notes must document the services that were provided. And as Janelle indicated, that can be in narrative or it can be in checklist format. Staff must empower the client toward goal completion. We all must believe in recovery. Our clients do get better. And again, they may not get better within a day, within a week, and thus client response to intervention, was one of my favorite on the old requirements, because I can't tell you the number of times that I read, client thanked me. That was the client's response to intervention. I got a note that says, stop tapping on desk. Okay, I shall. Oh, good, good. Well, role of community support. This is the definition of CPST. This is what CPST provides. And again, pay particular attention to the restoration, and what this says is restoring him or herself to the best possible functional level with the greatest degree of life quality enhancement, self-efficacy and recovery, resiliency, illness self-management, and symptom reduction possible. Again, we're moving those individuals that we provide care to a dependent status to an independent status, because our clients do get better and they don't need as much support from us. CPST requirements for billing. A billable unit of service may include either face-to-face, telephone contact, or in the future, video conferencing, because currently, as Dan had referenced earlier this morning, with our CPST rule and with the adjoining ODGFS rule, the coverage and limitation rule, it's currently involved in a federal lawsuit. So even though video conferencing is in our CPST rule, you can deliver it, you just can't bill for it. And we're hoping that one day, soon, we'll be able to bill for that. But currently, you cannot bill for CPST vis-a-vis video conferencing. It's between the mental health professional and the client, or an individual essential to the mental health treatment of the client, such as, and again, that's where the client tells you who is essential in their life, who is essential in their treatment, and who do they want to be involved in their care. The golden thread. Everyone's heard about the golden thread. It begins with the mental health assessment. The mental health assessment determines and justifies the diagnosis. It identifies the symptoms. It identifies what the consumer's personal goals are, what stressors, strengths, skills, and functional deficits the individual is facing. It also establishes baselines so that we know and the client knows when they're getting better. It also justifies the type and the intensity of services. It also prioritizes areas of needs and recommended service. The golden thread begins with the service plan goals, the service plan objectives, the interventions, and the progress notes. And we'll talk about all four of these. The service plan goals address the needs identified in the mental health assessment. The objectives are measurable changes in the consumer behavior or symptoms that are steps to meeting the specified goals. The interventions are the services or the modalities plus intensity appropriate to accomplish the objective. And lastly, the progress notes. They're tied to the ISP goals and objectives. They describe the intervention that's specified in the service plan. They also describe the progress towards the specified goals and objectives and recommendations for modifications to the ISP, as Janelle indicated earlier, if applicable. The documentation linkage should be viewed as a reflection of the golden thread, not the golden thread itself. The golden thread is the real connection between the assessed consumer needs, strengths, preferences, and personal goals, and the individual service plan and services provided. The clinical needs are identified through the mental health assessment. The clinical needs are transferred to the consumer's individualized service plan, and progress towards goals are reported in the consumer's progress notes. We had referenced a paradigm shift, and this is part of that paradigm shift. We were not taught to document and bill in a Medicaid environment. We were taught to provide services by following what supervisors and colleagues modeled for us. Supervisors must know and teach the requirements associated with the Medicaid rehabilitation option, as well as know and teach the clinical skills themselves. It's important to know. And again, we don't have 06 any longer. And 06 was a Medicaid compliance review. We now have a utilization review through ODJFS, through surveillance and utilization review. And what they do is data mining, and they look at outliers. So again, every year, as a mental health provider, you would prepare yourself for your Medicaid compliance review. And 3 weeks before the review, we would all scurry about, pull records, check them, make sure that we signed them. Again, if we did that throughout the year, and if we instituted a utilization management program within our agencies or a peer review process, we wouldn't have to worry about this. And if we learned the skills of how to bill in a Medicaid environment, we're going to be safe from all audits. Too often we are accustomed to doing for and not teaching skills that move someone from dependence to independence. If we change the way we are interacting to reflect a teaching modality, documentation of services has never been easier. But not without a major ideological shift in our approach to service delivery. What do our agencies tell us that CPST is? And again, earlier in our presentation, we referred to CPST as a direct clinical service. The other point that I've always addressed in training is ask yourself, as a mental health professional, why are you providing this service? Is it medically necessary? You know, I joke that my oldest daughter is now driving and has been driving for the last 2 years. And sometimes I have her transport me places. And as you know, in Ohio, transportation is not billable through Medicaid. It's the direct clinical intervention that you're providing. And sometimes she does provide a direct clinical intervention to me while she's transporting me. But I just don't bill it to Medicaid. So again, what do our agencies tell us that CPST is? And what is it really? Traditional approaches to community mental health emphasized, do anything the client needs you to do, or do whatever is necessary for the client. And we're shifting from that, which is inherently in conflict with current regulatory requirements associated with Medicaid as a funder, compared with block grants and other grant funding to serve this population. It's also in conflict with the recovery model. Today's supervisors and program directors are often teaching from a platform that is outdated and is not reflective of current regulatory and fiscal parameters, also known as oral tradition. Because when we got into this field, we learned some lessons that may not have been correct. And we kind of mirrored what our supervisors told us, and we also copied what our predecessors put in the record. And we just drafted it forward. And so what we're suggesting is something very different. Let's provide services based on client need. Let's understand what our clients need, and then let's deliver those services. And that's it. I think we've got us back on time. Look at that. Thank you. Tap, tap.
Well, I've hoped you've all heard some things that are different today. I hope that they've heard some things that are exciting about some of the changes, and I am 100% sure that there are a lot of questions because the information presented today is drastically different than what you've heard in the past. It really is creating a lot of flexibility in terms of how we document. It's allowing you the ability to utilize more effectively electronic records if you have them or if you're looking at using them. And it also is shifting the way we think about medical necessity from looking at the totality of the record rather than saying in every single note I have to justify every component of medical necessity. So with that, what we do want to do is open it up for questions. We will be bringing microphones around because we are audio recording this presentation today. So if you would like to ask a question, we would ask that you speak into the microphone. We are also have the note cards, so if you would prefer to write your question down, we will be having people come around through the aisles to collect those cards, and we will try to get through as many of those questions here today to get answers to them. And like I said, if we run out of time for the question and answer session, we will be putting together a written frequently asked questions document.
I have a court-ordered client, and custodial mother refuses to sign ISP. I sent it to her attorney and have documented in my notes every week I have called the attorney asking what the status is. This is a Medicaid child. Any suggestions?
I think you're doing what you need to be doing in terms of documenting your efforts to obtain parental signature. Is the attorney involved the guardian, or is the mother the guardian? The mother? As long as you document your efforts to obtain parental signature, you've satisfied the requirements of the rule.
My question is around level of care issues. You referenced in your presentation that the mental health assessment is to make recommendations for level of care, and I'm wondering if there is a process underway to operationalize that. And I ask because my county is developing a level of care protocol system for non-Medicaid services, and at some point they're anticipating that they may need to merge that to a parallel system being developed at ODMH.
What we are currently looking at statewide is not only levels of care, but also consistent definitions as it pertains to SPMI, SMD, SED, and then corresponding service packages. And we have a state committee that is comprised of both constituency groups, ODMH staff, stakeholders that is working on that process. So stay tuned.
Mike Witzke, Union County.
Hi, Mike.
Hi. These all kind of, they're three questions, but they're all related. Effective date, habilitative, and lastly, and it's not lastly, but I'll just stick with three. On page 22, you indicate that in the golden thread, the client's needs are identified through a mental health assessment. And what if the client identifies things, because you really emphasize client-driven, what if the client identifies things that they want to include in their treatment plan that you aren't in sync with your assessment of their mental health and in correspondence with that?
And again, it's their treatment plan. If they want to include things in there, then I encourage them to do so. And when you said effective date, is it the effective date of the rule? Again, one of the caveats that CMS has not been clear on, Mike, is the whole issue of children and services delivered to children. Because again, a lot of the services that are delivered under the psychiatric rehab option with kids can be construed as rehabilitative and can be construed as habilitative. Because again, with habilitative services, we're teaching new skills. And depending on where that individual is developmentally, they may not have ever learned those skills. So CMS has not been clear as it relates to kids and the whole issue of habilitative services that are delivered to kids versus rehabilitative services.
So am I within my realm of authority to say, I'm going to stop paying for those and I'll let you guys decide, and then if you decide against me, I'll pay them?
Well, I would have to confer with our legal staff on that one, Mike.
Well, just for the record, that's what I'm going to do.
Okay.
The rule went into effect February 15th.
I want to thank you first for the new progress note rule. We love it. And I want to ask if you foresee the possibility of eliminating the treatment plan as we know it and including treatment planning on progress notes like we do in primary care, if that's the movement that we're going to. You know, you in your primary care notes, you're writing the chief complaint for the day, and this is the plan between now and our next visit. Is that something the department is looking at?
You know, the department currently is looking at the integration of behavioral health care as well as what is happening on a federal level, and a lot remains unknown. But again, what we're trying to do is simplify and reduce administrative burden wherever possible. So again, stay tuned, because we're not sure what we're going to be moving on next. But again, it makes sense to integrate services and to become as simple as possible. Because one of the areas that I think have led to a lot of burnout with staff is the fact that behavioral health care, especially with Medicaid, has required so much more. And most people became very distraught in our system because they're here to deliver services. And what they were finding is that they were spending much more time documenting the service than they were delivering the service. So what we're hoping is a process to where we're going to simplify that and reduce that administrative burden to then be able to have providers deliver service. So again, that's something that we will certainly look at the department.
The definition of rehab services, as you showed on the screen, seems to integrate physical and mental health care.
It does, and it's based on the medical model.
Okay. It talks about the maximum reduction of physical or mental disability and restoration, blah, blah, blah. So for CPST, where do we draw the line? I'm assuming if we use that model of rehab services, a CPST worker could cue, remind, assist, and teach a client that had physical problems with those physical problems, if those physical problems impacted their mental health status, which, since they are closely aligned, physical and mental, seems like that they could do that and bill for that. Is that a correct assumption?
They could do that as long as those physical symptoms were impacting on their psychiatric symptomology. And again, that is part of CPST. And again, it's part of the teaching so that that individual can then do that for themselves.
I work for a treatment foster care agency where we provide CPST and counseling, but we also provide just strictly case management. So, for instance, following up on medical appointments and things like that that are required through the foster care system. Recently, we were told that we need to separate our progress notes so that, for instance, if we're providing CPST in one visit, but then also just doing some case management, that we'd have to do two separate progress notes, one for the CPST and one for the case management. And I don't know if this would be a question for you, Terry, or him, but would Medicaid object to having a side progress note about strictly case management, or is that something that you think should be separated in a chart?
Who is telling you to have separate notes, and who are you billing for the case management piece?
We don't bill anybody for the case management. That's strictly for foster care, ODJFS standards, and that kind of a thing.
Well, I'm going to defer to my colleague at ODJFS for that one.
Okay.
Yeah, I might have to actually go back because I don't know enough about the specifics to address a specific concern like that. So maybe afterwards we could talk just a little bit more and maybe a little detail. I may have to confer back with some others to see before I give you a specific recommendation one way or the other.
Because I had seen where, you know, if a provider is providing two separate billable services, like a case management, or I'm sorry, CPST and counseling, that you would have to do two separate notes about that. But I just wondered if that is also the case if one of the services isn't billable. So, okay, thank you.
When we're, in our role, we obviously speak to the requirements for our certified services. I know what some agencies have on their template that they use for their documentation as a place to put sort of billable time, where I think I referred people as one example, the Greater Cincinnati note, you have start time and stop time, and some create a way or format within the note itself to separate out that information so that you're not billing for something that clearly isn't billable.
I just have a comment about that question, and it's very similar to what Janelle, you just said, as far as 4E type reimbursable services and stuff that the county pays for in foster care. It's just very clear at how we document what time the billable service ends, and then at the bottom of that note, I've done an indentation of following this billable service, these following issues were addressed. And so it's not in the billable time, but you can see that we spent other time doing some items. So because it was all in the same time frame.
I just had a question about how to document the start and end time. Let's say you did a CPST service, same provider, from 9 to 9:30, and then later in the day, that same provider provided a CPST service to the same client from 12 to 12:30, and then maybe again from 4 to 4:30. And our electronic record does not allow us to enter multiple start and end times for one entry. So that would have to be a separate entry. And what I'm wondering is on that time from 9 to 9:30, if you did your note that was inclusive of the day, but then you had to do a separate actual billing entry, could you reference back to the 9 to 9:30 note and basically just say in your narrative part, C note with start time of 9 a.m.?
You need to have the ability to start and end time for each contact, and you also need to have the location tied in to each start and end time. So,
and I guess that's what I'm saying, is that there would be a separate sort of billing entry that had those things, but then in terms of actually doing the checklist, all the checklist, sort of the note portion, the progress note portion would just be on the one. I guess I'm just trying to think of a way that we can incorporate the new rule of only doing one note for multiple contacts with our electronic record system, where there is no ability to do multiple start and end times.
big smile, I think now I get it. Yeah, that would be fine. I think as long as the information is there. So yeah, as I understand it now, you got 9 to 9:30, you put all the coding, and then you just sort of handwriting narrative. Also saw client from 11 to 11:30 at the client's home, and saw them from 4 to 4:30 at the client's office. So it's kind of written within the body of the note. That's what you were...
Well, sort of, except for I'm saying we're going to have to actually, for billing purposes, we'd actually have to enter that as a separate time. So there's going to be something in the chart that also shows this 12 to 12:30 and that's where we'd write in the narrative to reference back to that 9 a.m. note.
Okay. Yeah, as I understand it, it's fine. You're documenting the information, and then your billing people will know how to enter the billing.
Okay.
Mm-hmm. In those same lines, we are in the same situation that she is. We have an electronic record, and you can just do one time and start time, stop time. So could we total all of our duration together, 80 minutes, and then in the narrative have the different times that we were with the client, and then the start and stop time and where they were?
Have you been able to talk to your vendors about making changes to the system?
Yes, but we cannot afford the changes that they... Yes.
So it's and we do recognize. I mean, one of the questions while we were working on this rule and having it, go forward was sometimes sort of the cost of that. And certainly if people, continue to document, usually, the formats, there's a couple of new elements like significant changes or events in the life of the client. Those are accrediting body requirements anyway. So we did recognize that, and this doesn't require a change to that. It certainly makes it easier if you can do that. All I can say is it needs to be clear of start and stop time and location. So how that is done, if you need for billing purposes to have it, but then have a way that it is separated out on the note, but you just need to make sure that you would have a policy about that staff are trained, that they're following that. And that would be perhaps a concern. But you might develop, like I said, you're not developing a template because you have that. But as long as it's clear in the documentation for each note, that's not a problem. So we don't want to make it, again, sort of flexible in how you show that. So we don't want the relief that this offers, to conflict with sort of the reality of your systems until the time you can get it changed.
I had a quick question about this paradigm shift in thinking here. In the past, feedback from audits had been that you should be able to differentiate a time of the session, like a 30-minute CPST to a 90-minute CPST, it sounds like if we move to this checkbox system, even in your narratives, those notes will look relatively similar with different times. Is that correct?
That's correct. You might have, like on a checkbox system, when the department gets their examples finished and posted, you'll see check all that apply. So it might be 2 types of interventions, 3 types of interventions. Again, you know, it's combined. If you're documenting, you know, I think, if you saw a client twice in a day, does it really matter that whatever significance you felt that you might do some narrative, does it really matter that it happened during the 11 to 11:30 session, or was it during the 1 to 2 session? Just making sure that the information that needs to be documented is what's key.
Probably for Terry then, if I have 4 6-minute CPSD interventions, have I now met criteria for billable time? Or does each individual one have to meet the criteria?
And thank you for saying that one's for Terry.
I said probably.
Keep in mind that a billable unit of service is 8 minutes. Okay? Now, with our McSys system, we also know that it's some in rounds. But again, a billable unit of service is 8 minutes in duration.
So being able to bill for all the service, or do a note for all the services in a day, does not equal being able to tally the minutes for that?
I think we're talking about a billable note and what happens at the end of the day when those services are summed in round. Because at the end of the day, you're going to get paid for 24 minutes. But in order for those services to be billed, it has to be 8 minutes in duration. Do you understand the distinction?
Intervention.
The system's going to bill the 4 notes, all right? So at the end of the day, you're going to get paid for 24 minutes. And again, that's a disconnect between what is supposed to be billed and what McSys does at the end of the day.
Right.
And what McSys does at the end of the day is it sum rounds. But the rule is it has to be 8 minutes in duration.
That's what I thought. Okay.
Are there other questions? If not, I will start reading a few. The first one, 42 CFR 440.130. Therefore, habilitation is not billable. Is that true or false?
Again, the question is rehabilitation versus habilitation. The question that you have to ask yourself, and the question that is not clarified by CMS as it relates to children. And again, is it a habilitative service that is being billed through the psychiatric rehab option if the individual has never gained those skills? The question that you have to ask yourself is, where is that person developmentally? And what are you providing that's clinically appropriate for that child? It's a whole different ballgame with adults, but with kids it's less clear. And CMS has not registered an opinion or put that opinion in writing, and we're still waiting for that.
Kind of following that same vein, for an elderly home-based clients or referred clients that may have dementia, how will this meet the rehabilitation model?
Again, with dementia, you have to ask yourself, does the person have the sufficient cognitive ability to be able to benefit from the service? And if you can't demonstrate that that person is benefiting from that treatment, then I would not bill for it.
Another question for you, Terry. Can you explain the difference between CPST and case management? And since the comment was made that CPST is not case management, that case management is linkage and referral and not billable, does this mean CPST linkage and referral is now not billable?
Let me answer the last piece first. CPST is billable, and a component of CPST is linkage and referral. The difference that I tried to expound in the presentation is that case management has a very different federal definition than CPST, and case management is not a direct clinical service, whereas CPST is a direct clinical service. And again, our current rule, there are 10 activities that can be delivered vis-a-vis CPST that are billable, which include coordination, linkage, and referral. But the difference is CPST is a direct clinical service and is one of the 6 covered Medicaid services in Ohio. Therein lies the difference.
The question was, do case notes need to specifically state which goal the therapist and client were working on? For example, therapist and client addressed goal 1 and used relaxation techniques to address anxiety issues.
The answer is no.
Next question, does everyone billing for services have to be on the ISP? For example, what if supervisor not on the ISP basically steps in for the regular clinician and provides a service? Is this billable?
That's fine.
I have a follow-up question to that in terms of system-wide. If you have more than one agency and more than one provider working with a client, can you speak about integrated ISPs and what the guidance would be on that?
More than one provider within the agency or within
system-wide. So 2 different agencies working with the same client on behalf of the client.
Okay. Well, each agency would need to have their own ISP for the client. Starting back with the diagnostic assessment, you wouldn't have to repeat it, but there is a requirement that if an agency gets an assessment that's completed by somebody else, that they review it. So they would still want to be looking at it clinically. Each would develop an ISP. Certainly they can be sharing the information if you have the appropriate release of information, that this is hopefully a coordination of care and not duplicative care. Does that answer the question?
Yeah, in the past, I believe the mandate was that you work together and try to develop one ISP, even if it was across providers for that particular client.
I mean, you could have the same ISP, but are both agencies working on the same goals, the same service, working on the same goals? Is everything, what's different? I guess that would be my question. What's different about what the 2 agencies are each individually bringing to the table on behalf of the client?
I think probably the prime example would be medication management from a mental health center and more CPST home-based services from an outreach, an agency that does outreach, both working on behalf of the client. I mean, it's fine if we can both have our ISPs. I think in the past it was a little cumbersome to try to develop one ISP across agencies.
Because what I'm hearing, you have the 2 different services there, so I would expect to see some differences. But again, hopefully the agencies do work together on that. But when it comes, one of the things I'll talk about is what is the rule, and there's no rule that says when 2 separate agencies work with the same client, they must have the exact same ISP, nor is there a rule that says that there must be a completely different ISP. So what you want to try to do is have your coordination to the benefit of the client and not duplicate services. How best that is met, really it's flexible and up to the agencies involved.
I had a question about diagnostic assessments. Oftentimes, I work with children, and oftentimes they would have had perhaps 2 or 3 in the duration of 1 year. Relative to where they've been placed in part of their different treatment plans. Is there a cap on how many diagnostic assessments, mental health assessments, that you can bill for within 1 year? I know physicals for children, there is a cap on. You will only pay, I think it's 1 a year.
And again, what I would have you reference is a mental health assessment rule, that if there is a change in the clinical status or in the level of care, certainly a diagnostic assessment can be updated. However, Medicaid does not have a limit on the number of mental health assessments that it will reimburse an agency for within a year. Medicare does, and that is 1 every 3 years.
Okay, thank you.
You're welcome.
Next question, is assessing screening for metabolic disorders, which may be the result of psychotropic medication, billable as pharmacological management?
In your clinical documentation, you have to be able to reflect how this is addressing the psychiatric symptomology. Because again, there is mainstream Medicaid that pays for physical health care, and I recognize the federal reform and moving towards integration of care, but also recognize that our pot of dollars is much more limited. So again, if it is affecting or having direct contributions to the mental health symptomology, and your documentation reflects that, then that's something that you can bill for.
Regarding the CPST case management differentiation, how does this square with COA? They don't recognize CPST, they accredit us as providing case management.
The department has a deemed status crosswalk, which identifies, based upon what services that you're certified for by the department, which services or programs you have to be accredited in by your accrediting organization. In that regard, we look at the activities that comprise the different services, not really the name.
Is there a limit to the number of persons one staff clinician can have in a group?
No. I'm getting good at this.
Overlapping services with multiple services, multiple providers. How do we bill so that we do not overlap for services? For example, CPST from 9 to 9:45, pharmacological management from 9:46 to 10:15, and then CPST from 10:30 to 11:30. How does this get billed?
If I understand it, I mean, you're documenting each session. I'm going to presume it's the same provider. I think I heard 2 CPST sessions in that day and 1 farm management. So you have a CPST note, did a daily note, and it shows the times from, I think, was 9 to 9:30 and 11 to 11:30. You, again, differentiate. You have on that note somehow the 2 different times and the location code and then the farm management, but that information could, if I understand it correctly, that information should go to whoever does your billing at your agency in the same way you would do now with 2 separate progress notes for it, for the CPST and 1 note for the farm management. And you've clearly showed that the times are not overlapping.
Can you do 1 note for 2 different service codes, for example, CPST and individual counseling if provided by the same person?
No, it has to be, if the same person provides 2 different services in the same day, then it has to be 2 separate notes.
Is there a limit to the amount of time you can have on a log? For example, our current form, there's a 100-minute limit per note.
No.
Is email intervention a billable CPST service if a copy of the email is required or placed in the progress note?
No.
Can you bill Medicaid for a provisional diagnosis, and if so, where is the rule?
You can use a provisional diagnosis, and again, what is important is that you're assessing that individual and that you're clarifying what the diagnosis is, and as you engage that individual and gain more information, then you should have an accurate diagnosis. Because again, I can't tell you the number of records that we've looked at where there's 5 or 6 different diagnoses in the record, and they're not provisional. And again, there may be a different diagnosis that's ascribed by the psychiatrist, then from the CPST, then from the clinician. So again, what's important is that the treatment team gets together and arrives at 1 singular diagnosis.
Can we get some clarification on the staff-to-client ratio in groups?
There is not one that's prescribed in the rule.
Can you clarify on the development of the ISP? Is it 5 sessions or 30 days, whichever is more? And what would you write on a progress note under the new rule before an ISP is developed?
Okay, the ISP has to be developed within 5 sessions or 30 days, whichever comes last. And you would document that the same way that you're documenting now. I mean, I would ask, what are you doing within that note or within that session, and what information needs to be written down? I assume part of those sessions are working on and discussing the ISP, and document the information that needs to be included. There's sort of no magic answer to it. Again, I'll go back to clinical, documenting based upon clinical need.
If I'm utilizing a signature or signature sheet, does the signature have to be the same as on state licensure? For example, if a middle name is written out on the license, does it have to also be written out on my signature?
Well, that's the first time for that question. So, no.
What is the state's policy on electronic signatures?
We reference, within our administrative code rule, we reference the revised code. It's the section is under the Department of Health, and I don't know it off the top of my head. It's certainly with electronic records and signatures, you have to meet those security requirements of access, and I think they say it's like you can utilize a signature by a computer-generated pen, a unique combination of letters and numbers that is unique to the individual provider. In the intent and explanation documentation for that section of the rule, the progress note rule, I do give the revised code section, so you can look that up, or you can email me and I can send you the link.
If we utilize the SoQuick format in our current electronic record system, will we be able to continue to use this format and meet the requirements of this change?
Yeah, I would make sure and remind staff to include, again, significant changes or events in the life of the client. When you look at some of the different notes, the CPST or counseling, a lot of them they don't use that terminology, and that's one of the things is, to get away from looking at terminology and what's the intent of the standard. And even in looking at those SoQuick notes, you'll see things, important updates on a progress. I don't have a copy of them in front of me, so I think if that information is there, that's what's key. And recommendation for modification to the ISP. I know a couple of agencies said they're just going to add a little checkbox, I think, in the section that talks about there's some checkboxes for diagnostic assessment update, and they thought they were going to add a checkbox there for themselves.
And in a similar vein, do I understand that there will no longer be a SoQuick progress note and that agencies are free to develop their own?
Well, agencies have always been free to develop their own. So SoQuick was never a mandatory requirement. We're just, like I said, not going to continue to update it based upon this rule change. And there are other rule changes that we're looking at, and we hopefully now have some, now that we've got this one finished, some more time to also offer some regulatory relief to agencies.
Janelle mentioned one note per service per day, per staff per day. Is this regardless of the modifier?
Yes.
And I'm going to wrap this up because we do want to get to our provider panel, and I do still have a stack of questions, so please know that we are doing a frequently asked question. If your question did not get specifically addressed, we will be including that in our frequently asked questions document. Do we need to indicate if transportation was provided in the note? And if so, must you indicate the specific intervention in the drive?
As Terry talked about during his presentation, transportation is not an intervention. It's not the intervention. That goes back to, do you need a mental health person to provide that service? And no, you don't need to have a mental health person provide transportation. The rule requires that you document the interventions. So if while you're transporting the person, there's a mental health service is being delivered during part of that time, then certainly that's the intervention that you would be documenting. There is no requirement in and of itself that transportation is listed on your progress note.
And I think, too, this is an artifact of 6 reviews when we were told, don't put transportation in your note, and then we became very clever about using terminology such as access to community resources. So again, we're no longer doing the Medicaid compliance reviews. So I know that many of us still need EMDR. But with that in mind, again, as Janelle indicated, just include the intervention that you're billing for as part of that note. It doesn't matter whether or not you put transportation in the note.
With that, I do want to move into kind of the next part of this session, which is to actually give you the opportunity to hear from some provider organizations that have already begun to implement this process and change their way that they document based on the flexibility that's allowed in this rule. The 3 providers have all participated in the pilot process, and they're here today to just share with you kind of the lessons that they've learned and the experiences that they've had, and to share with you the examples. You do have copies of their progress notes that they are currently using in your packets on the right-hand side towards the very back. They have included them in the PowerPoint presentation. They are very hard to read on the overhead, so you might want to go ahead and pull those out for references. And with that, I'd like to introduce our 3 presenters. First, you will hear from Michael Kaufman. He is the Clinical Director for Appleseed Community Mental Health Center. He will be followed by Amy Flesher, who is the QA Director and Compliance Officer for Greater Cincinnati Behavioral Health. And she will be followed by Lee Johnson, who is the Director of Risk Management for Wingspan Care Group. And with that, I'd like to welcome Michael.
I would like to thank Daniel Arnold from Ohio Jobs and Family Services, Janelle Pagano, and Terry Jones from ODMH, and Teresa Lampwell from the Ohio Council. I'm a relatively new clinical director at Appleseed. Just passed my 2-year anniversary in April, but I consider myself fortunate to be considered in this project. Likewise, I'm grateful that you allowed me to learn a little bit of what you do, speaking to the panel itself over here to my right. The experience of talking with Terry Jones and Teresa Lampwell in particular has helped me to see, in part, the necessary work they do in struggling with rules, regulations, and mandates. I've learned much from this panel over the past few months, and I have seen your passion for the field of counseling, and more specifically, your belief in reducing documentation woes for the people that do the grunt work in the trenches. So thank you very much. Likewise, also thanks to Lee Johnson and Amy Flesher for processing the past few seminars with me. I appreciate your dialogue. In the next 15 minutes, I'm going to share with you what our experience has been like in implementing this rule to our internal processes at Appleseed. You will note our forms in your packet are a work of progress, as is our process in reorganizing ourselves to assimilate and accommodate this new and not so new information. Let's go. Okay. Appleseed is a small rural community mental health center located in what is considered Northeast Ohio. Appleseed is about 70 miles north of Columbus and is located in Ashland, Ohio. We started out in 1991, way back in 1991, with 2 psychologists, 2 CTs, counselor trainees, I was one of those, 3 CSPs. Now, if you can remember CSP, you're dating yourself. 2 secretaries and 1 part-time psychiatrist. We have now a staff of over 60 employees, and we serve a population base of about 55,000 in Ashland County, for all of Ashland County. Now, that might be small potatoes in comparison to some of the larger agencies represented here today, but like I've told people before, we like to think of ourselves as a little giant when it comes to offering the services that we have. For a small agency, the bar in clinical excellence is set high. As you can see, the number of services and the type of services that we provide. You can refer to the PowerPoint handout regarding our services. The Progress Note Project. We became interested in the project in early 2009 as we finished a 6-month project retooling our ISP. We worked real hard for 6 months researching and talking with Terry Jones about what it means to produce a really good ISP. We're not changing it for nothing. That was an arduous process, and we're proud that we've got something that we think is going to help us into the future and also help us with the new progress note rule. We also participated in the brief project with the CPST note project with ODMH, and this gave me an opportunity to personally express an interest in understanding and making documentation more meaningful to the clinician, to the members of that committee. While waiting to hear about the upcoming project, those of us on the ISP project decided to formulate a committee and dedicated our work to looking at efficiencies within the agency. There are 4 to 6 of us on that committee, and we are on the OCD side, and we make up that group we're lovingly known as the tweakers. Now, for this group of people, the project note project seemed like the next logical step. I notified Dana Harlow of our interest, who then notified Teresa Lampole from the Ohio Council, and that's how we became involved. Because the note was new, we wanted to be at the forefront of learning about these changes so that we can ready ourselves to understand and adapt quickly to new mandates and be prepared for those awful audits to come. We don't know what's happening, so we want to be prepared. We want to be ready. We think that we're ready, or becoming so. So the reaction. I got to tell you about the reaction. As we understood this rule, we created the forms you see, and they are in your packet. Some of those are still in process. And then we took a few counselors and CPST workers and ran a pilot for a couple of weeks. Like many of you, we discovered that we interpreted the old rule in a distorted way. When we obtained the correct understanding of the old rule with the paradigm of the new rule, we had some very unusual experiences. So much so that I could describe it to you, being clinically oriented, in 4 distinct stages that occurs with such frequency that I've come up with a name for the phenomena: DSS, Documentation Shock Syndrome. I've even thought about a whole approach to this. DDT is the approach, which stands for don't do that, followed by an intervention, TBF. The TBF approach is 2 before, and we're still in the midst of evaluating that. But the first phase, I got to share with you, the first phase is confusion. There's a slow recognition that something had changed among the clinicians. You might experience that yourself. This is not right. That's not how it was done. We're used to making bricks without straw. You don't understand. We used to document everything. Now you're telling us to be brief and focus on progress or lack thereof and tie the documentation to the treatment plan. What do you mean? Be brief? What are we to make of this? And then the second phase. This is the shortest lived phase, by the way, so you'll see it and then you won't see it. Euphoria, a lifting of affect, and intermittent relief. But no one wants to admit or talk about it because this feeling in the work setting is somewhat uncomfortable. So, back to mistrust. The third phase. We must go back to our old religion. The gods will not be pleased if we do not offer the sacrifice of verbiage in our documentation. And then the fourth phase, which I consider the hardest phase, slow acceptance. Acknowledgement that this is real. This is a little freeing. But clinicians admit that they still lack the skill of knowing what and how to document in this new way, because before they documented everything. They covered the proverbial rear end, the back door, there, you get the picture. This slow acceptance is now leading to the acknowledgement of change of the second order, long-term and significant change, and clinically that's the kind of change that you want. First order change, you attempt to rectify a problem by looking at the solution, and the first order change almost never works. It's the definition of insanity, doing the same thing over and over and over and expecting something different to happen. It just doesn't work. That's first order change. Second order change is where the change is long-term and sustainable. In our pilot, we recognize the need to rethink how and why we document. If we can understand the basis for good documentation, and of course the rule supports this, we can position ourselves to focus more clearly on treatment outcomes based on documentation that reflects progress, not process. There's a difference. Progress towards clients' goals, wishes, and preferences. Our biggest hurdle is learning how to be brief. I teach a class on brief therapy, and I tell my students, you can be brief if you slow down, if you do it slowly. You can be brief. So it means that we have to retool ourselves at the agency to slow down in our thinking, to be brief, and save ourselves some time and headaches in the future. Now, I have to tell you that some of the clinicians are going back to documenting everything to justify time spent with the client, simply because of habit. And I have to admit, the lack of accountability to move in a different direction. So as an administrator, I have to hold my people accountable to this new paradigm. But old paradigms die hard. We found the rule provides us with a format that is flexible enough to permit us to individualize our forms to suit our own needs. We're now concentrating on connecting treatment through the golden thread, and we are emphasizing this. With less paperwork demanded, I believe we can discourage, or we can discourse in a more thoughtful manner of how we will take care of the client. Imagine that. We know all too well that more work, especially paperwork, significantly contributes to burnout, decreased quality of care, and affects productivity. You have taken a look at our forms. They're still in process. Remember, we're a small agency. We are not electronic. We are electronic only in the sense that we have these forms on MS Word. 2003, and we're operating on XP, if that gives you any kind of idea of where we're at. A little bit behind the game on some of you other service providers. But we have a chance to individualize our forms, and the advantage of this is that we're really not spending a lot of money at this time on software. So in the two forms presented, we wanted to provide the basics for what we felt we needed for the form under the rule and make it easy on the eyes. There's something to be said for face validity. So we think, not being electronic, that we've provided a form that the clinicians can look at and say, oh, okay, that looks simple, that looks easy to fill out, rather than fainting when they see complex forms like we used to provide for our clinicians. And of course you can't see these up here. The counseling note, you'll see two supervisor signatures. We've axed one of those supervisor signatures and put client signature as optional. It still needs some discussion, but basically tweaked for our own internal purposes so the format will not change much. And on some of the notes that are provided, the examples, you'll see that our clinicians, and I think Janelle was right, the licensed clinicians are having the hardest time. That's what we found out. And you'll see that they're still process-oriented. So it's going to take some time and some dedication. Now, briefly, anticipated efficiencies and changes that have been a result of this new rule. Some of those changes are happening now. Some of these efficiencies are happening now. Not all of them. But these efficiencies are our goals. If we're not meeting them, then this is something that we want to strive to meet in the short future. April 5th was our official start date using the new notes based on the rule to supplement the new note in our ISP. We have implemented an open forum every Tuesday at 8:30 to discuss treatment plan creation and progress note writing. In those meetings, we are emphasizing the use of the treatment plan more specifically and also tying it to the progress note with the client's goal in mind. So we're really dovetailing treatment, and we're really having good dialogue about what it takes to honor the client in the documentation and also to reflect good quality care, and it can be done. I'm convinced of that. Our QA process is also being redesigned to pick up those people who need to be recommended to that team meeting or that meeting. Sometimes maybe being mandated to come to that meeting because of the review of the charts. So we're changing the format of the QA process. Another shift in QA, when we review charts, we're not looking to see if it is there just to cover medical necessity, but we're seeing if it's connected, if their progress is connected, and if there is movement. And in the short future, if there's no movement, I'm going to want to know why. We anticipated reduced time in completing documentation, and that is now happening almost across the board. You have some people getting it, some people not getting it. For those who have gotten it, one of our supported employment specialists, I asked him how the documentation was going, and he said, he just looked at me and his jaw dropped and he said, "Oh my." And I thought, oh my, because I didn't know what Arlen was saying. Was this good or was this bad? And he told me that the documentation cut his time in half with the normal time it took for him to fill out paperwork. Significant. Now you've got some people who I checked on last week, and the caseworker said, you know, I'm still struggling with it. So, reduced time. And the clinicians also like the new rule in how to document. So those are a few of the efficiencies. And how does this position us then for the future? Well, the rule helps us to be more aware of the relevance of the golden thread and also what I call the Goldilocks treatment, not too much, not too little, but just the right amount of treatment. We think that with clarity in the progress note, the treatment is going to show in our outcomes in the documentation. Then we can utilize brief outcomes to measure not the best practice, but the individual clinician. We want to know, or I want to know, if that individual clinician is making a difference, and that's where we're headed. And I think the reduction in the paperwork demands is going to help us to do that. We think the new rule and wrestling with this process has helped us to appreciate how documentation can truly honor the client and their hope in us to move them forward. The record, while being a legal document, should also be a very brief reflection of that journey. On behalf of Appleseed, we want to thank ODMH, ODJFS, and the Ohio Council for hearing those who work in the trenches and do the grunt work of providing mental health treatment. Thanks for being responsive to our needs, and thank you again for letting me personally ride the bus with you these past few months. Thank you.
Hello, everyone. My name's Amy Flesher. I'm the Quality Assurance Director and Compliance Officer for Greater Cincinnati Behavioral Health Services, also known as GCB. I'm here today with my CEO, Tony DiTillo. Some of you know him. He rode up here with me. I also would like to thank the Ohio Council and Teresa for pulling this training together and including us, and just all their efforts to support agencies outside of this particular effort also, and to ODMH and ODJFS for implementing these rules that will help us reduce administrative burdens so that we can spend more time doing what we do. Obviously, from our title, we're located in Cincinnati. Not a stretch there. We are in Hamilton County. We're a large urban SMD provider. We serve about 3,400 SMD adults. We're adult-only agency, and that is about 400 different individuals throughout the year. We have 8 or 9 traditional case management teams. Sorry, Terry, we still use that term. We haven't come up with a better name yet. We have several ACT teams, including some specialty ACT teams, mental health court, a forensic ACT, IDDT team. And we also have 13 psychiatrists on staff. We have psychiatric nursing, payee services, we have counseling, day programming, vocational services, the full array of different vocational services. We have about 140 direct service staff. 75% of our services are field-based, and we primarily provide CPST and farm management services. Our current status of our electronic health record or electronic medical record is that we don't have one. We have things on paper. We have an electronic document management system. So instead of trying to make our field-based services fit into a facility-based software, which most of them are in the behavioral health field, we still do everything on paper, and we scan it, and they're available electronic. All of our paper images are available electronically now, and we just started doing this in December, and part of our plan is to start to automate the extraction of some of these data elements to be incorporated into a database and then available again in some electronic format, either through reporting or back onto another form, or that kind of thing. So that's what we look like down in Cincinnati right now at GCB. Where we stand with the progress note rule change is that we did participate in the ODMH pilot last year, and we have not implemented the draft note that you'll find in your packet. That is a draft version. We came together and pulled that together pretty quickly. That was our interpretation of the rule at the time, but having gone through this training now 5 times, I think I understand it a little bit better, and we might be willing and able to incorporate even some more efficiencies into that draft note. We're hoping that we can roll this out so that our staff can begin benefiting from these efficiencies by no later than July 1st. But our draft note, as you'll see in the packet, is now one-sided. Our CPST progress note was 2 sides, front and back. It was 12 separate sections. It was a lot of writing, and that meant whether it's an 8-service phone call or an 8-minute phone call service or 2 hours of CPST in the field. So you had to do the same amount of documentation for all of that. We're anticipating with the number of ACT teams that you saw that we have that we will really see some big savings in time through the hoops that people have to jump through and filling out front and back for each of those services. We're estimating from that pilot and from some focus groups that we did run this draft through that we're going to be able to shave anywhere from 5 to 10 minutes off of each progress note. And what that means for us at GCB, we provide on a slow month 12,000 CPST services. On a busy month, that can be as high as 18,000 CPST services. So times that into front and back, that's how many pages of writing our staff are doing. So if we, on the low end, take 12,000 notes a month and shave 5 minutes off, that gives us 1,000 hours of time that we'll be saving in 1 month. And again, that's a conservative estimate. That's not incorporating the ability to put more than one service in a day into one note, which we don't even know what that's going to look like for us yet, but it's going to be big. And we know that we're minimally going to probably cut our time in half. We're also excited about the checkbox format that will allow us to extract more data with our software that I described earlier. And the real big saving for us and for me as a compliance officer is the understanding that we will not have to document in each progress note the need for services. So really, our front and back two-page progress note is what I call a mini assessment right now. So if we really can focus that on being just a progress note and not having to go through all of those mental hurdles, that's going to have a huge impact on documentation time for us too and our staff. Our challenges we're expecting is that this is going to require a huge amount of training. As Michael said, it's just we have so many processes in place right now where we're coaching staff back about things to include in how do you describe client response. It's not thank you for the service, as Terry mentioned earlier. What does client response mean? Well, client response isn't even there anymore. We've got rid of that section. So, and the other piece that we have in our note that we got rid of is the functional impairment section, which we call the mini assessment. The why does this person need a mental health professional for this service. So that's gone. So people won't have to go through that anymore. And I think that that's going to take a long time for people to really believe that, because we spend so much time coaching staff on how to do that. And the struggle from the management level with this rule was, yeah, we're liking the less documentation, but we're still struggling with you have to have enough and the right stuff to provide the information that you need for care coordination, liability issues, and utilization management. We're anticipating some other changes because it's just such a part of our culture. We have progress note reviews, we have peer reviews that are going to be impacted by this. So we want to do a really formal pilot and be able to anticipate all those changes and be really progressive so that with our staff, so that we're kind of addressing their concerns and getting their questions answered up front before we even roll this new form out. It is so much more than just a new form. It's really a new way of thinking about the way they do their job every day, and we want to make sure that we're supporting them in that. So even though this is exciting, we're still going to be faced with our 75% field-based services, and we're not anticipating a lot of benefit in that area for efficiencies related to our EHR. The staff feedback that did participate in the pilot of this draft that you have in your packet was that we love it. Can we start using it now? And we're like, no, hold on. We got a lot more to do. The next question is there going to be more space if I need it? As I said, we're going to have to go through a lot of training and provide a lot of support to staff that they feel comfortable writing less. All the staff, and especially the supervisors, felt that it's a much better flow and much more clear to read a summary of progress for one day versus all of these piecemeal notes front and back that may happen within an hour of each other, and trying to go through each of those hoops for each specific intervention. Everybody's looking forward to that. And the ability to roll multiple services into one day, staff just can't believe that it's a reality. One of the other questions that staff had frequently was, when is an event significant? And I think Janelle has put together a lot of really helpful information in the intent document that's in your packet also, that we'll be able to use in our training of staff now. And again, here's our sample note is in the packet, but this is just an example of what our first interpretation of the rule. And you'll see some of the things at the top, how we only had enough room for 3. I don't think we have a lot of times where we're doing more than 3 services in one day of any given type, but that's what we built in for the sample, and that might be something that we change if we find out there are more, if there's a need for more than that. But when I was talking about our scanning software, that's why we had those weird little comb shapes and things in there. That's for our data extraction. But this is what we've come up with right now. As I said, I already expect there to be some changes as a result of going through these trainings. But if you have any questions about how we came up with this, feel free to contact me. And again, thanks to everybody for the opportunity to participate in this, these events.
My name is Lee Johnson. I'm the Director of Risk Management at Wingspan Care Group. We're up in the Cleveland area. I wanted to say thank you to the Ohio Council, ODMH, and ODJFS for allowing the Wingspan affiliate agencies, both Applewood and Belfair, the opportunity to participate in the pilot and also in this series of trainings. And also for taking the lead in moving the mental health community in this positive direction that will allow us, that will allow the field the opportunity to improve client access to care, staff retention and morale, and to align mental health with the rest of healthcare. Just to give you a sense of who we are, Wingspan and the affiliate agencies are the result of the affiliation of a couple of behavioral health care agencies with Wingspan. Applewood, and both Applewood and Belfair have deep roots in the Cleveland area. Applewood's the result of a merger of three agencies: Children's Aid Society, Child Guidance, and the Jones Home. And you can see from the slide here how long those agencies have been around. And Belfair was founded in 1868 as an orphanage for children orphaned in the Civil War. Wingspan is a nonprofit that was born out of Belfair in '02, and we affiliated with Applewood in '08. Both Belfair and Applewood deliver services. We're kids agencies, children and families, to over 18,000 children and families annually from nearly all 88 counties in Ohio and other states. We have residential treatment. We have foster care and adoption. We do pharmacological management services, school-based services, and PH services. Belfair is duly certified in AOD and mental health, and both Belfair and Applewood each have school programs to facilitate education for children. Belfair targets specifically children with autism, and the Gerson School at Applewood works with kids with mental health issues that prevent them from being able to achieve success in their traditional school settings. And they both have independent and transitional living programs and homeless youth outreach programs as well. All right, so in terms of the rule, we participated in the pilot, and we implemented the CPST note in March, and very happy to report that the efficiency gain that we saw in the pilot, we also saw that continued when we implemented the progress note, of people reporting about a 50% reduction in the time it takes to document the service. So that's certainly the upside. And then the related upsides with that in terms of the positive staff feedback, people feeling very good about the change in terms of the staff. We have to balance that with the potential challenges, but we welcome those challenges. And basically the way that we think about this rule change is that it's taken the it's empowered us to be able to think clinically about how we document the services and decide how we want to create our rules and processes to most appropriately document the care that we deliver to clients, instead of really just thinking about how to deal with the elements of the rule and meeting the rule. So the challenges that we have to think about in terms of how far to go in terms of gaining efficiency would be the ability to clinically supervise staff, because all of our staff are not independently licensed. Compliance oversight, to ensure that people are appropriately delivering and documenting services. And with that flexibility for creating checkboxes, given the that we provide, we see that risk management has more of a challenge of creating multiple templates. Before this rule, we basically had one progress note that you could deliver any service on. And now with developing checkboxes that basically make specialized documents for each service type, we'll have more templates. But we welcome that challenge as well. In terms of rolling out the new progress note, especially with the CPST note, and just in general educating staff about the rule, just as with my peers here who have also talked about the changes at their agency or the rolling it out at their respective agencies, the yes you can use check boxes. Now, at our agencies, we had already begun the use of check boxes. We had implemented a checkbox diagnostic assessment, so we didn't have quite as big a hurdle there, but using check boxes more thoroughly and completely throughout the documentation was welcomed. And yes, you can write more than one contact on a note. That certainly went over well with staff who deliver CPST services and other programs in which there are multiple contacts in a day. And yes, you can refer to the mental health assessment and ISP to demonstrate medical necessity. And that is, we were very much trained and training in the justify the need for service in every note, right to document or to prove that you spent the amount of time that you spent in the session. And so those two pieces were very well received, and we're still trying to help staff understand that that really is true, that you don't have to write a page if you spent a lot of time with a client. So write less generally. The CPST note implementation went over very well, relatively easily, and I've given you an example in the packet of the CPST note, and then we had the trauma-focused behavioral counseling note. We actually already had and just had to tweak it with the rule change. We were already using that with one specific program that we're running in Lorain County, and so we're working on now those specialized notes for the different counseling programs that we have and the different types of services that we have. In terms of electronic record, we have an almost complete electronic intake process. The exception is some of our school-based services that do not participate with the centralized intake because it doesn't make sense for it to happen in that way. They're not electronic, but all of the residential and the foster care and so many of the other programs use electronic intake. And we have a pilot happening right now on the Belfair side with an electronic ISP. And so this rule change happened at a really nice time for us, so that hopefully we can just continue to move forward as we work towards the achievement of that electronic record. Before I get into the notes, some of the questions I was wanting to respond to that people asked, just from an agency perspective. In terms of documenting, and you can see with our CPST note, we have client time and we have staff time on that note. The staff time is the non-billable time, so that we can capture both on one night's note, so that we as an agency have decided not to have staff write two notes for that, but instead to capture the non-billable time with the staff time. We also use that so that we can track how much it costs to deliver service, because as we all know, the cost is more than just the face-to-face, intervention time with a client. And then in terms of documenting the start and end times, generally this rule, the efficiency gained is supposed to be on the documentation and not necessarily on the billing or data entry end. So even though you can document multiple service contacts on each note, you still want, at least from our perspective, we still want to capture what time each of those interventions happen. First of all, to make sure that you don't get, I know in our billing system, if there are two services delivered at the same time to a client, that's a red flag, and then services get kicked out for that. So you don't want to roll them all up, at the beginning of the day, because you might get into a conflict with double billing if other services happen that day. And also, you want to be able to have that pure documentation time so that you can avoid that. And then in terms of the staff-to-client ratios, I know people were like, what do you mean there's no staff-to-client ratio? You probably want to check with your accreditation requirements because they often have requirements on staff-to-client ratios. So that might be where your agencies are coming from there in limiting that. But going on to the CPST note, I guess I think it's pretty self-explanatory. You've seen a couple of other examples. We have 3 contacts on the CPST note. This was the easiest note to do, obviously, because of the defined interventions that CPST, the prescribed interventions that CPST has, and so it was easiest to roll out first. We do ask that people tie the intervention to the activity that day because we see that justifies the golden thread, so to speak, and the medical necessity. We put the additional requirements in the new note to document significant life changes or recommended modifications to the ISP. We put those at the end of the note so that you could document that there. And I think that's pretty much it in terms of that note. And then the counseling note, you can't get the full benefit on it just with the printout, with the hard copy, because there are drop-down boxes under each of those different intervention areas in addition to the check boxes at the bottom. So staff have the ability to not have to document the whole